I've been a physician for 15 years. I came out here from the Gulf Coast, from Mobile, Alabama. And my first experience of the Northwest was interviewing for residency positions. And one of my first experiences of the Northwest was humbling, if not humiliating. I somehow managed to click the wrong button on my application, and I signed up for the Spanish-only tract at a clinic in Seattle called CMAR. And I learned of my error sitting around a table with all these other interviewees, and me and this other guy out of 20 were the only ones who signed up for the Spanish-only tract. He did it on purpose. So I got the experience of going around to 4 different doctors, interviewing me, explaining how I was wasting their time with my monolingualness, how I didn't speak a lick of Spanish. You buy a fancy interview suit, you fly across the country, and then you waste everyone's time. And flash forward 9 years into the future, I'm hurling myself into this free clinic full of Spanish-speaking patients. You would think I had learned my lesson. Thank God I didn't. Gracias a Dios. So after residency, I spent 6 years working at a regular clinic, a hospital-owned clinic, being busy and well-paid. I would see about 4,000 visits a year. My salary came to $1 million by the time I worked 6 years before taxes. But I slowly came to perceive, to apprehend what I call the game. This context non-conducive to informed consent. This context not conducive to the uninhibited flourishing of human potential, aka wealth. This us versus them mentality that exists inside the financial pressure cooker of the real world, of the real clinics. This us versus them mentality that we would justify raising our fee scales every year to compensate for the high cost of insuring the staff, for buying medical insurance for our staff. So I quit my job after 6 years, not knowing what would come next, not understanding the why of it all. Then about a year later, I was shown the free clinic out of the Union Gospel Mission. And again, I didn't know what I was getting myself into when I walked into the office of the director of the mission. I didn't know there was a group of intrepid local medical students from Pacific Northwest University running the place, generating about 150 visits a year with their efforts. And I didn't understand there were thousands of uninsured Spanish-speaking patients in our county waiting to fill the void when we expanded our schedule. The void in the clinic and the void in my life. And so I kind of plunged into it, threw the full force of my life behind it, not knowing what to expect. And I learned all these lessons, sort of like what Adam was talking about. I learned to be dependent on others, and man, that was hard. I would go to clinic every morning not knowing if we'd have enough interpreters or if we'd have any interpreters. But I stayed on the wave. And I want to tell you what it's like doing what we do. And not what it's like, what it is doing what we do. It's riding this wave of triumph and suffering and just hanging in there. It's perpetual, repetitive concussions of astonishment. It's seeing this network of volunteers and community donations and community support, community self-expression, self-assemble around me. It's indescribable. But the pressure to futilely attempt to describe it is irresistible. Last year in 2014, 30-something odd clinicians, volunteer interpreters, nurses, medical assistants, and more came together to create 12,000 free medical care encounters, scattered across the community in homes and parks, across Facebook and email, but primarily in these little satellite clinics based out of churches and the main clinic out of the Union Gospel Mission on 1st Street, which is actually an old hotel meeting room that was converted into a clinic, never with the intent of it lasting this long or being this busy. We continue to get a lot of support from Memorial Hospital, who gives us free labs and x-rays and scans worth hundreds of thousands of dollars every year. We combine that with donations from our patients, who supply all the money we need to purchase the medicines that we have to keep on hand all the time inside our little clinics. And we combine that with community support, these micro donations of supplies and medicines, and put all the ingredients together with the time and attention of the volunteers and create millions of dollars worth of free medical care. And we infuse that value into the community, often among community members who feel valueless. And the love is reciprocal. They clothe us. I'm wearing some shoes that were given to me, huaraches, I should say. They feed us. They decorate our walls with their art. And they decorate our lives with their stories. We've managed to raise $3-point-something million to construct a new clinic, complete with long-term housing for the men and women of the missions rehab programs. Raised really rapidly, a feat unprecedented in the 80-year history of the Union Gospel Mission Clinic. We've also created our first part-time job. We have a medical director, part-time medical director, Alondra, who's out here being embarrassed, I'm sure. Your badge is blurry, but your face ain't. While I'm embarrassing you, let's talk about some of her feats, no pun, before she became Fancy Pants medical director. This is her buying shoes for one of our patients, Alicia, and this is her with Antonio, Alicia's husband. Last summer, when Antonio was still alive, we visited them in their little apartment down by the fairgrounds. They were sweltering in the heat. They were packed into this little apartment with all these boxes of dialysis equipment. Alicia was his nurse, plus confidant, plus wife, doing peritoneal dialysis on him every day, or several times a week. And they were sweltering in the heat. And within a day, Alondra figured out how to get a little window unit installed, purchased and installed. She's probably out there shaking her head like it's no big deal. But I was there, it was a big deal, it was astonishing. I saw the relief on their face, the before and after. I saw the love reflected in their faces. I should tell you about Carol on the left, our physical therapist, who figured out how to get a man fresh off the bus from Nevada with this artificial leg cobbled together with duct tape, a new refurbished leg, and how he danced in the waiting room when he got his new leg. And that's good because that's his business card. He's a children's party entertainer. A clown. I should spend time dispelling some myths, I usually do. Our patients aren't all drug addicts and homeless. Most agricultural workers don't have access to health insurance. The Affordable Care Act did not eliminate the uninsured citizen in our county. But one more audience participation thing. Raise your hand if you or someone you loved has had difficulty affording their medical bills. And keep them up if you or someone you loved has filed bankruptcy, wholly or partly because of medical bills. That's why. We can't have it like this. We can't have a system that makes you poor and scared and broke. It makes you sick. Healthcare isn't that. Let's contrast the real world to our world in the gift clinic. In the real world, most of you know you've navigated this. To get access to your doctor, you navigate the phone tree, you show up on time for your appointment, you wait to be checked in, you wait some more for the nurse, tell the nurse some personal stuff, get your vital signs taken, get stuck in a room, and usually you're told, just keep it to one problem. The doctor's very busy. Well, part of the reason the doctor's so busy is because of these onerous charting requirements that get crazier every year. I managed to get an official copy from a real clinic, from the real world, of the charting requirements. It goes on for pages. I'm not sure if this is like privileged material or what. I won't bore you with the details. Ted might censor it. But not only do they have to deal with charting requirements, they have to deal with these crazy new coding systems called ICD-10. These are the codes we use to diagnose conditions and get reimbursed for our bills we submit. And these are legitimate diagnoses that are coming down the pipe, supposedly in another couple months, like underdosing of appetite depressants, T50.5x6A. Bizarre personal appearance. I look forward to using that in lab skills. Struck by non-venomous lizard and struck by duck. These are the I invented my own, glared at menacingly by shepherd. Perhaps it will only be used in veterinary medicine, but I think it's legit. Now, if you contrast that to our world, the free clinic world, patients don't need to compete for our attention. They don't have to prove they're worthy. There's no merit hoop to jump through. If they show up, we see them. And likewise, our charting requirements are a little different. This is hard to read, but the only thing you need to see is the top line. Chart notes must be succinct yet amusing. And a lot of it's redacted anyway to protect our trade secrets and the people with sensitive stomachs. But you end up with these quotes from our charts. These are legitimate quotes from our charts. And what this culture of playfulness permits is for the clinicians and patients to get down to the sacred stuff, the communing with each other in the room, the learning from each other how to survive in this crazy world, and then transmitting that information to the next person in the future. communing with people as they experience the overwhelming. And even as we get to the point where time and disease do their inevitable work, and all we have left is our companionship, we get to cultivate the conditions of dignity and humor. Imagine it. Clinicians unhinged from the parasitizing bureaucracy in the room, laughing with their patients in the face of death. That's what we do. This is one of our official forms. You have to put your name and date of birth and phone number. And some people, fill out more. That's supposed to be for our section, but Chris wanted to come. I should tell you about how Dr. Jorgensen on the left took Senior B to the hospital in the middle of the night, or how Senior B's cat was attacking our phlebotomy equipment and stethoscope tubes during a house call, and the sound of a 92-year-old with a hoarse voice laughing at his cat. But instead, I want to talk about truth. Truth is rediscovered beneath layers of certainty, beneath layers of dogma that obscure and distort. This comes into play when we discuss certain lucrative practices in medicine, like cancer screening. It relates to the bedrock foundational moral imperative of Western medicine, the Declaration of Helsinki, that came out of the Nuremberg trials after World War II, that enshrines patients' rights to informed decision-making, not to be experimented on without their informed decision. It relates to this ideal of informed consent, this process where a dialogue between clinician and patient results in a decision emerging. There's no recommendations, there's no twisting of arms, there's no fear in informed consent. How many of you are aware of the concept of overdiagnosis as it relates to cancer screening? It's very different than a false positive. Overdiagnosis, at least with mammograms, let's do mammograms. You can detect a cancer, an abnormality, biopsy and prove it's cancer, treat it and survive, but if you had never discovered it, it was never going to cause you symptoms in your whole life, much less kill you. The experience of an overdiagnosis is the same as the experience of an early detection, which is the benefit of cancer screening. It has taken us 25 years or so to figure out this balance of risk and benefit, and it's different for different age groups and different risk factors. But in general, women between 40 and 50, if they undergo a screening mammogram, the cancer is detected, and they survive, the odds are 10 to 1 that they were overdiagnosed. This understanding, this concept, is very hard to transmit in a discussion in the exam room with advertisements like this. This appeared during the Seattle Seahawks playoff game 2 years ago. And it tells the story of a young woman, I presume between 40 and 50, definitely not over 50. And she had her life saved by a screening mammogram. Her family's health was preserved because of this test. Nowhere in this advertisement is there room for the possibility of the tragedy of an overdiagnosis. This gets in the way of informed consent. This is a version of coercion. It uses fear to sell a medical product, and it gets in the way of understanding. It inserts fear into our discussions. And over the last 15 years, people have shared a lot with me about their fears. Primarily their fear of scarcity, primarily surrounding the green tickets, money, the currency of social interaction. And people are afraid to go without. They're afraid in the future they'll go without. And the reason this is so ubiquitous is how money is created. It's created through a process called fractional reserve lending, whereby the monetary supply is expanded through loans. The problem is the interest on the loan is not created in this process. This sets up a game of musical chairs where we have to compete with each other for a finite amount of currency to pay off our personal debts. And this is the pressure underlying the game. But also over the last 15 years, I've received tremendous gifts from my patients. They've taught me the wisdom of their gut. I'll explain in a minute. They've taught me that everyone feels joy when they're useful to the other, when they freely give of themselves. This is universal in all the clinics I've been to. Doctors often spend hours cataloging perplexing lists of symptoms that we can't figure out. We'll attribute it to what we call somatic disorders, or functional problems, or idiopathic, which just means we don't know. But if we interrupt that process of cataloging and suffering through these symptoms, and simply ask the individual, what do you feel this is? It triggers this interesting reflex. It connects people to their right brain, their nonverbal, holistic part of their body that's connected to the gut, that's sending these visceral signals, trying to get the attention of the left brain, which is trapped in its language, enslaved in the little boxes of definitions. And when we ask that question, we confirm this suspicion that people have that they can get a handle on this, they can figure this out, they can feel their way through this. And it's amazing to see. It's amazing the wisdom people carry around in their gut. All right, one more audience participation thing. Look to your left, the person on your left, look to the person on your right. And this time feel an awe, because they're still here. Despite all this pressure, all this dogma of scarcity and separation, all this debt, we're still here, feeling our way through this thing. And it tells me we're going to be okay. This guy tells me we're going to be okay. Kenny, who I met the first month I was at the mission clinic, he had just started the rehab program at the mission. He still volunteers at the mission. He's doing great now. He's an artist, plays guitar, and he does the best impression ever. I staked my career on this. Bill Murray in Caddyshack, that you've ever heard. I could listen to it all day. He does it in front of the medical students, and I just keep him going. Didn't you caddy for the llama once? And he just goes. As long as there are people like this, these are pictures from over 4 years. A lot of these people are doctors now, they were medical students at the time. As long as people feel joy when they give of themselves, as long as people feel revulsion in their gut when they hear about people going without medical care because they don't have the right document or enough green tickets, we're going to be okay. And I know we're going to be okay because last Thursday, I was at the satellite clinic at Holy Family, like I usually am from 5 to 8, entertaining med students. Patients don't show up there much, it's usually slow. And just like every Thursday, Dr. Jorgensen, who's supposed to leave with me and go to Holy Family, is stuck in the mission clinic with a room full of Spanish speakers. She doesn't speak any Spanish. And she was on the phone for 90 minutes talking to people in Seattle, trying to figure out a way to get a cochlear implant for this woman who recently went deaf. It's an uninsured woman. This woman had already found a surgeon to do the surgery. She just needs the device. And Jorgensen, before she's done, the whole waiting room is trying to help. They're trying to help this woman they've all just met. They're brainstorming about fundraising. They want to get on Spanish radio and TV and newspapers. As long as people are like that, they feel their way through. They don't accept the barriers. We're going to be all right. Thank you.